Hi, and welcome to the ToxFox, a central hub for all things toxicology. My name's Anastasia, and I'm an emergency medicine resident in California. Today's episode is all about the hypotensive bradycardic patient. In the emergency room, we see a lot of hypotensive patients, but they're usually tachycardic to compensate. When we see somebody with a slow heart rate and hypotensive, we should tell ourselves that that is not physiologically normal. The differential diagnosis for this type of patient can be categorized into medical causes and tox causes. In terms of the medical causes, this can be due to a cardiac abnormality such as an inferior MI or high-degree heart block, electrolyte abnormalities such as hyperkalemia, and endocrine disorders such as hypothyroidism and adrenal insufficiency. There's a couple of other miscellaneous items that can cause it, such as low blood sugar and low body temperature as well. In terms of tox causes, this can be due to beta blockers, calcium channel blockers, clonidine, which is an alpha-2 agonist, or digoxin. Here's our case. We have a 78-year-old female who has a history of depression and high blood pressure. Her home medications include atenolol and amlodipine. When she arrives, she has a normal body temperature, she's bradycardic, hypotensive, but setting well in room air. She tells you that she took a lot of her atenolol in a suicide attempt. Her troponin is normal, her electrolytes are grossly normal as well, her EKG doesn't show any kind of ischemic changes, and her blood glucose is 55. How do we manage a beta blocker overdose, which this seems to be? Step 1. We start off just like we do for any other critically ill patient. IV, O2, monitor, pads on the patient, and advanced airway at the bedside. This patient is phonating, so we don't need to intubate. Step 2. Give the crystalloid solution of your choosing to hopefully increase that blood pressure. I personally like Normasol, but you can also reach for normal saline if that's more readily available in your hospital. Step 3. Give atropine. The dose is 1 milligram every 3 to 5 minutes for a max dose of 3 milligrams. Atropine will act on the vagus nerve and help decrease the parasympathetic stimulation, and thus will increase your heart rate. Step 4. You want to give IV calcium. The dosing is 3 grams calcium gluconate and 1 gram calcium chloride. Calcium will help cause vasoconstriction. Step 5. Give glucagon. Glucagon binds to a receptor that activates a similar pathway to beta receptors and thus can bypass the beta blockade. You want to give 5 to 10 milligrams IV as a bolus, followed by a drip at 5 to 10 milligrams per hour. You want to give Zofran because these patients will become very nauseous. Step 6. Start your pressor or blood pressure augmenting medication. We naturally gravitate towards norepinephrine in the emergency room, but vasopressin is a good second-line agent. Step 7. Give insulin. We are very comfortable with giving insulin for diabetic ketoacidosis. We have to remember, though, that insulin is going to be very important for calcium channel blocker and beta blocker overdoses as well. You want to start off by giving 1 unit per kilogram as a bolus, followed by a drip at 0.5 to 1 milligram per kilogram per hour. Insulin will help with inotropy, and it will also help perfuse vital organs. Step 8. Give intralipid. Intralipid will bind to fat-soluble molecules and will help them be metabolized in the liver. Step 9. Start ECMO. We can essentially put you on a machine that will act as your heart and your lungs and will get you through the critical period. On the boards, it's important to note that calcium channel blockers are associated with hyperglycemia, while beta blockers are associated with hypoglycemia. This is because the efflux of insulin from a cell is dependent on calcium influx into the cell. If you have a lot of calcium channel blockers on board, the calcium is not getting in, the insulin is not getting out, and your sugar remains high. You also want to remember that calcium channel blockers and beta blockers are not easily dialysable. There are some exceptions, but for the most part, dialysis is not going to be the answer. What about the other 2 medications that we mentioned that could cause hypotension and bradycardia, these being digoxin and clonidine? If you suspect a digoxin overdose, you want to give Digifab, which is a digoxin-specific antibody. If you suspect clonidine, you want to give high-dose Narcan, 10 milligrams, supportive care, and potentially start a pressor. Clonidine overdose will present very similarly to an opiate overdose. They'll have myotic pupils, have decreased respiratory drive, and be altered. The key difference here is that if you physically stimulate somebody with clonidine overdose, their vital signs and altered mental status will improve. As soon as you stop stimulating them, their vital signs are going to tank. With opiate overdose, stimulation shouldn't cause these kinds of changes. So let's recap. Hypotension with bradycardia is not physiologically normal. You want to consider cardiac etiologies, endocrine, and electrolyte abnormalities. You also want to think about your beta blockers, your calcium channel blockers, digoxin, and clonidine. Give high-dose insulin, Digifab for digoxin overdose, and Narcan for clonidine. Thanks for watching the ToxFox, and see you next week.